Today we will be studying coronary perforation. So first we should know that what is the incidence of coronary perforation. It is less than 1%, that is 0.1 to 0.9%. Okay. So first of all, I'll go to the risk factor of the coronary. What is the definition of the coronary perforation? This is the uh, coronary vessel injury resulting through and through the vessel wall. Okay. Then next is the what are the risk factors. Risk factors can be clinical risk factors like patient's age, that is advanced age, mi, then renal failure, female sex. Then for the lesion specific, that is complex lesions like bifurcations, then ctos, bifurcation, then ctos. uh, and when the vessel specific, more common with the tortuous vessel, these are L6 and RCA. Then occurs the guide wire. If we are using hydrophilic guide wires, stiff guide wires, and if their debulking tools are used like atherectomy, thrombectomy, and then if there is like the other coronary intervention devices like IVers, aspiration, and guide liner catheter extensions has been used. According to balloon, if it is non-compliant balloon, if it is cutting balloon is oversized, over dilated, higher pressures are used, post dilation has been done, or balloon has been ruptured. Okay, so these are main risk factors. Okay, so next is the classification is depending upon the severity. That is class 1, it only stains the wall and there is no extravasation. In 2 there is extravasation of the blood, but the hole is only less than 1 mm. In 3rd it is hole is less than 1 mm. But when you inject the contrast, there is no contrast at extravasation. In 3 it is more severe and it is hole is more than 1 mm and contrast extravasation is seen, as well as there is number 4 is number 4 is that is cavity, it is spilling into a cardiovascular cavity, like we say a coronary cameral fistula. Okay, now based on the mechanism, it can be large vessel, then can be distal vessel, then can be collateral septal or any other collateral epicardial arteries. These are mainly during the retrograde approach for CTO. So now we come to the how to treat these perforations. So these are the most treated perforation intervention cardiologist can uh, can get. Okay, so first of all, universal algorithms for coronary perforation, and other is the type specific. So universal algorithm is like inflate the balloon and occlude the vessel, then inject a contrast to confirm if the perforation is closed or not. The sizing of the balloon should be in 1:1 ratio, and it should be 6 to 8 mm pressure, that to be used, so as to avoid overinflation. Now next is like according to give IV fluids, vasopressors, according to the BP of the patient, then pericardiocentesis, if there is cardiac tamponade, which can be confirmed by echo, and auto transfuse the blood, and then notify the surgeons if it does not stop. Now comes to the type specific lesions. If we have all done this and still there is if there is no extravasation, then monitor the patient. If there is extravasation, then treat the cause. Then type specific treatment, there are large vessel and the small vessel. In large vessel you can of course give prolonged inflations, balloon inflation, then covered stents. The dissection techniques are there. Next is the embolization of the fat. For the distal vessel you can give, distal vessels are small, so maybe you must not be needing that vessel, then you can give the embolization of the fat and coils. Then covered stent, if the perforation is at the origin of the branch. Okay, so now if still extravasation is there, then cardiac surgeon should be called, and the reversal, all the hardware should be removed, and the reversal of the anticoagulation to be done. So now what are the types of the covered stent? Mainly PK papyrus covered stent, which can be passed through the 5F, and it is better trackable, that is mold removable. It is single stent design. Next is the graph muster. Means I have seen this graph muster. This graph muster stent. So this is graph muster sandwich stent design. It can be passed through 6 French. Then reversal should be, protamine is given, which is 1 to 1.5 mg, neutralizes the 10 units of heparin. Up to 50 mg can be given, and in the patients who have fish allergy, caution should be taken that it should be given slowly. Okay, so now coming to the large vessel perforation. Because we know overinflation, high pressure, severe calcium, balloon rupture, atherectomy, guide wire exit from microcatheter. Okay, so this we know. Next we come to, okay, how do we do it? First of all, prolonged inflation that I have told. Then covered stents. Two techniques are there. Covered stent. First is the single guide wire. If you have used a bigger guiding catheter, okay, like 7 French or 8 French, then you can use this. So first of all, it is called block and delivery technique. So what will you do? So this is your aorta, and this is your proximal vessel, and this is the perforation. So you will this wire is already has been passed. You have inflated a balloon across this wire. Okay, so now what will you do? Then you will pass another wire. I should use a pen. Then you should pass another wire. And for that you have to deflate the balloon and then pass another wire. Okay, then again inflate the balloon, because the main purpose of this is to decrease the extravasation of the blood, so that cardiac tamponade does not occur, blood loss does not occur. Okay, so now covered stents. Then we will thread over the cover stent over this wire. Then the previous wire and this balloon is removed, and then covered stent is deployed. Okay, so we have deployed the cover stent, and then we will confirm if this thing has perforation has closed or not. Okay, so next here comes the ping pong technique. So ping pong technique, it uses dual guide techniques. Like suppose if we have not used a bigger guiding catheter, so what we can do, you will, like earlier only, you will inflate the balloon across the perforation. Then the first guiding catheter is pulled back into the aorta. Okay, then the second guiding catheter is used to hook the vessel. Then we will hook the vessel with the second guiding catheter, and then second wire is advanced through the second guiding catheter. Now what we will do, then the balloon is transiently deflated for the passage of the second wire. Second wire will only cross if the balloon is deflated. Okay, then reinflate the balloon, and then the cover stent is threaded over the second guide wire. So then remove the balloon and the first wire, and then cover stent is deployed after the inflation of balloon, and remove the first wire, and then hemostasis is achieved, and then confirm if it is sealed or not. So now comes the dissection technique. Well, this is in very detail, and I am studying for my exam, so I don't think I will be able to write this much. So that's why I have read only. Yeah, it is like that. So orthogonal. So mainly, first of all, you will have to look into orthogonal views to locate the exact site of perforation. Then what we will do, we will inflate the balloon at the site. Okay, now we will cross subintimally. We can cross subintimally, retrogradely or anterogradely. Okay, like our aim is to make, suppose if this is the perforation. Okay, now we will cross subintimally. Maybe we have crossed subintimally here. Okay, and now we try to make a flap of this, and then try to make a flap of this, and try to cover this perforation. So we'll cross subintimally, and then we will make a subintimal flap to seal the perforation. Okay, Okay, next here comes the distal. I don't know, I made one page more notes, but I lost those things. Okay, so here is the what is this? Okay, so next is distal coronary perforation. Causes are mainly advancement of the guide wire balloon. Mainly causes are the advancement of the guide wire of balloon microcatheter into the distal small branches. Collimator has been used, so we are not even looking that where are these perforations occur or not. Stiff jacketed wire. So prolonged treatment is the prolonged inflammation, usually not preferred for these distal perforations. Okay, now then what we will do, embolization. Embolization can be done with the fat, coil, gel form, thrombus or wire fragments also. So what is the difference between the fat and coil? Fat, it is visible, not visible. Okay, it is visible. Control delivery cannot be done. It can be done. Microcatheter, any microcatheter can be used. Slightly larger microcatheter is used. So availability, fat is anywhere available, and often limited. Cost is no cost, and this is high. So what usually, I have not written it here, but you take fat from the femoral aspect of the particular patient, and then put it into the, and then we will isolate the flat globules, and then put it into the microcatheter. And mainly microcatheter which is used, microcatheter fine cross is needed, and the fat is 0.014 or 0.18 inches it is needed, and it can be crossed through the 6F also. So this is very simple. We will first of all, similarly we will go inflate the balloon. We will go and inflate the balloon, then balloon is deflated, and then another wire is passed, and then we will put microcatheter across that another wire, and then we will re-inflate the balloon again, and then while we will give the contrast to localize the balloon, and then re-inflate the balloon again, and via that microcatheter then the coil or fat are delivered. So next, another thing is we can put cover stent if this thing perforation is at the origin of the distal branch. That can also be used. So the one thing I have not written here is that it is very most dreadful complication. It can be prevented. How it can be prevented? First of all, look for the be cautious and look for any perforation at early time, so that it does not lead to hemodynamic collapse. And second, whenever you can use workhorse wires, and when the work of the polyjacketed wire has been done, these should be exchanged with the workhorse wires. Okay, that's all.